Hello, everyone. I want to welcome you to today's webinar. I'm very excited to be joined by a colleague of mine, Angela Craig. My name is Michelle DeGloria. I work for Baxter's Medical Affairs Department, and one of my primary responsibilities is providing the opportunity for clinicians to receive education on a virtual platform, all focused on best practices. Just a couple of housekeeping notes at the very beginning. Just wanted to let you know that following the presentation, there will be a QR code at the end. We would appreciate any feedback that you have. There's also an opportunity for you to identify topics for future consideration. We value that feedback and look forward to receiving those evaluations. Any questions that you have during the presentation, please enter those in either the chat box or into the Q&A box, and those will be answered at the end of the presentation. We are also recording this session, and we will make the recording available to everyone who's attending today and those that have registered and who may not have been able to join us live. So without further ado, I welcome the opportunity to thank Angela for joining us today to talk about this very important topic. And I just wanted to let you know, as I said earlier, she is a colleague of mine. I've had the opportunity to work with her, not only as a colleague, but also when she was still working at her organization. So this is a tremendous pleasure and opportunity for me here. So as I said, Angela's current employer is Baxter, where she is employed as a medical science liaison with a focus on the evidence and best practices for fluid management. She has maintained her temporary position at Cookeville Regional Medical Center, where she was the clinical nurse specialist of the ICU for 16 years. There, she chaired the hospital sepsis team and led her hospital to be the first sepsis disease-specific certified hospital in the state of Tennessee. And she currently maintains her position on the Sepsis Alliance Advisory as a board member. Angela has a passion for making outcomes for sepsis in all patients a priority. She has worked with area nursing homes, long-term care facilities, home health, and EMS to increase early identification of potential infections and how to best treat them. She has been an invited speaker at local, state, and national events on the topics of sepsis and hemodynamics. Her clinical experience includes being a clinical nurse specialist for 25 years, faculty at a community college, working in the ICU, telemetry, and congestive heart failure programs. Angela's passion for improving patient care have resulted in publications in the AACN, Journal of Advanced Critical Care, and as a contributing author for the book of Critical Care Nursing Certification Review. While work is an important part of her life, she knows that it is also important to balance. So when it comes to her time off, she loves to do the following: spending time with her grandbabies, spending time with her family. She's been married for 34 years. She has lots of animals, horses, cats, dogs, and her husband runs Rocky Top Aussie's business. She also loves hiking, shopping, going to the lake, singing, playing the piano, and even occasionally the trumpet. So without further ado, it is my pleasure to welcome Angela and pass it over to her.
Thank you. Oh my goodness, you read all of my bio. I just thought you might take just a little piece of it, but you got to hear my family stuff too. So do I just select take control? Is that what I do? Okay, I will take control. And so I think I'm going to, okay, now I'll hit share. Excuse me just a moment. Let me get set up here. Welcome, everyone. Ooh. Okay, let's see if we can, are you able to see the slides now?
Yes, just in, there we go.
Okay,
perfect.
2 seconds.
Oh.
Okay, excellent. So let's chat about detecting signs of sepsis, what's new and what's coming. So thank you for that introduction. And I'm super excited to talk to you about sepsis. It's near and dear to my heart. I'm extremely passionate about this topic, and we have a lot to cover, so I'm just going to quickly quickly get going. You can see she's already pretty much shared my disclosures, so that's there for you. And we are going to talk about how CMS, what those CMS updates are, how value-based purchasing can affect a hospital in the U.S. We're going to talk about some best practices for sepsis teams, and then really review the role of patient monitoring as well in sepsis detection, and review tips for evaluating your organization's sepsis program. So I hope this is helpful to you. So when we talk about what's new, when I say new, it's kind of relative. Value-based purchasing, we found out about it last year that it was truly going to, I think we all knew it was coming, but it is coming and it is here and upon us. So we kind of want to talk through how these value-based purchasing how this will affect a hospital, or how it could. But I think in order to explain that, we need to talk about CMS, and not to oversimplify it, but to simplify it. In case people don't know, CMS is the Centers for Medicare and Medicaid Services. It is our U.S. Is the U.S. federal agency, works with state governments, helps to manage that Medicare program and administer Medicaid and Children's Health Insurance program. Now, what CMS does is there are certain standards, which they're called core quality measures, that are set forth by CMS to hospitals, and they say you need to comply or you may be penalized. So what it does, there's like this bucket, and for hospitals who don't comply, they're penalized. So then there's some extra in this bucket for hospitals that do well. They get reimbursement. So it makes a huge difference, and it can be very impactful financially to a hospital. So we need to do well. More importantly, though, than just checking the boxes with CMS, to me, it's about patient care and doing the right thing for our patient. But we'll talk a lot about that as we go along. So when we talk about value-based purchasing, there are 4 domains. You can see here on this screen 4 different colors, and the main domain we're going to focus on is the purple one for safety. Now, there is a baseline period for sepsis, which is already done and over with. That was January 1, 2022 to December 31st, 2022. So whatever happened then, that's what happened, and that's the information we take. And they also then have allowed what's called a performance period for sepsis. And that is where we're at now. The performance period started in January of this year, and it goes until December 31st of 2024. Okay, so that's where we're at. The goal is to try to do as well as we can in hopes that we do better than what we did in 2022. And I'll explain to you some of the goals as well, some of the thresholds. So we have what's called the achievement threshold. And so it's slightly above the current national average of CMS compliance of 58%. The goal is 0.597482. So right about 60 percentile. Now, I don't know about you, but for me, where I've worked, that's a challenge sometimes to get to that 60th percentile even. It's a very difficult core measure to meet because it's an all or nothing core measure. So meaning there's a 6-hour bundle and a 3-hour bundle. There are multiple things in the 3-hour bundle, multiple things in the 6-hour bundle. And if you don't get every single one of them correct and documented the way it needs to be documented, then you fall out. So it's a high opportunity to fall out. So you really have to have processes in place which it can help you be successful. Now, then there's the benchmark sepsis, and the benchmark represents that top performance standard for the measure. It reflects the national top decile performance. And you can see that percent down here is 84%. So that is going to be the cream of the crop. People who get 84 percentile are doing excellent with CMS. Now, here I've just kind of blown this up so you can see this a little better. And you can see here, sepsis is down here, and it's in that measure that's with the CAUTI and the CLABSI and the MRSA, those kinds of things. And so it will affect us very, very soon. Now, what is SEP1? SEP1 is shorthand for the sepsis bundle with CMS. And the sepsis bundle with CMS is the severe sepsis and septic shock management bundle. So what it's doing is it's laying out these guidelines for us, for all of us who are fighting sepsis. And it really does try to help us focus on timely sepsis recognition and early emphasis with life-saving therapies. And the goal is the timing, right? Because we know that every hour of delay before a septic patient is treated is associated with 4 to 9% increased risk of mortality. So that's really a focus. And so there's timelines associated with what we have to get done. Now, sorry, I'm having trouble advancing my slides. There we go. I feel like I want to kind of do a little review of what CMS guidelines say versus the national guidelines. And I think it's important that we understand the difference between the two. So here's an example of what this looks like. If you've seen this, if you're an abstractor, these are the abstraction guidelines for inpatient quality measure sepsis, okay? These come out every 6 months. And you can see they're updated every 6 months. So you have to review these every 6 months so you know if there's any changes. And the people who abstracted these charts really have to know, okay? Now, what they say that we have to do within 3 hours, and it's within 3 hours of determining the patient has severe sepsis or septic shock, we measure a lactate, obtain blood cultures prior to administration of antibiotics, give those broad spectrum antibiotics, and then administer 30 ml per kg of crystalloid if they're hypotensive or they have a lactate that's greater than or equal to 4. I think we all know that bundle, right? And then you have this 6-hour bundle that you apply vasopressors if the patient is hypotensive and does not respond to initial fluid. You really want to maintain that mean arterial pressure of greater than or equal to 65. And then if you have persistent hypotension after your initial fluid administration, or if that lactate is greater than or equal to 4, you have to do a reassessment of volume status and tissue perfusion. It has to be documented. And then we also have to remeasure lactate if that initial lactate is elevated by any means. So anything greater than 2 has to be reevaluated within that 6-hour time period. Now that's based on CMS. Now, we've got what's called international guidelines for sepsis. And sometimes I see everybody focusing on the guidelines for CMS, but I think it's very important if you have a healthy program, you need to understand and see what the international guidelines for sepsis say. And so these came out in 2021. I'm looking forward to seeing what the new ones will be in 2025, but they are updated every 4 years. Now, what's a little bit different about CMS versus the national guidelines. So Surviving Sepsis Campaign recommends a 1-hour bundle. And honestly, I think most of us, if we're being honest, we really do welcome this hour 1 bundle to get everything started. And then, but then it's just, CMS gives us 3 hours to do most of this, 6 hours to do the vasopressors. So we just want to make sure our patient is well perfused and is taken good care of. So notice everything's very similar, measuring that lactate, remeasuring it if the initial one is elevated greater than 2, getting those blood cultures, administering broad spectrum antibiotics, and beginning that rapid administration of 30 ml per kg for hypotension or a lactate greater than or equal to 4. And then they've also added in this one, applying vasopressors if they're hypotensive during or after fluid resuscitation to maintain that mean arterial pressure of greater than or equal to 65. Now, I'm going to break this down into a variety of things. I want to kind of do a little parallel between what CMS requires versus what the national guidelines require. So we're going to just term this as best practices for sepsis teams. And number one, I would say know the guidelines and definitions. Know the CMS guidelines and definitions, know the national guidelines and definitions. And I think that's really important. So I'm going to kind of just do a synopsis. You can see here, this is the Surviving Sepsis Campaign recommendation highlights. And so basically, these are the national guidelines you can see in 2012, 2016, and 2021. We're going to start with the definitions. In 2016, they took out the severe sepsis category. The challenge is CMS still has severe sepsis as one of those definitions, right? So many of us have stuck with, when I say many of us, I know at the hospital I work at on rare occasion now, since I'm full-time with Baxter, we still focus on the definitions by CMS. Sometimes that can be challenging when the national guidelines say there's just sepsis and septic shock. But let me just go over the CMS definitions with you just very quickly. Now, mainly there's not really, per CMS, we don't have to send them data on sepsis. So I'm going to just mention that sepsis is known or suspected infection plus 2 or more SIRS criteria. But just due to time, I'm going to flip through the SIRS criteria. I think we all know the SIRS criteria, but I do want to mention this, that there are non-pregnant SIRS criteria and there are pregnant SIRS criteria. I decided it was time for me to update my presentation. I would always just focus on the adult. And by the way, this is an adult presentation. There are different SIRS criteria for pediatrics as well. So those are very easy to find. If you need help with that, please feel free to let me know. But notice the pregnant 20 weeks through day 3 post-delivery criteria, they are a little bit different than what for the non-pregnant criteria. Now, severe sepsis is a known or suspected infection plus 2 or more SIRS plus organ dysfunction. Now, organ dysfunction, I'm going to skip through this slide and go to this one because once again, I've added the pregnant criteria as well. So you can see the non-pregnant patient's organ dysfunction versus the pregnant patient's organ dysfunction, and it's 20 weeks through day 3 post-delivery, right? And so just to give you an idea, there are very specific criteria based on blood pressure, based on respiratory failure, based on your creatinine. And so you can definitely see the difference there. Like for instance, creatinine greater than 2 for non-pregnant, creatinine greater than 1.2 for pregnant 20 weeks through day 3. So I think it's important that you have that when you are doing your screening in those other areas, in the pregnancy areas. And by the way, it's important that we are screening our mamas too, right? And our pregnant moms, it's very important not to leave that group out or not to say just because we have the criteria now. Okay. And septic shock is considered, really the worst of all, but known or suspected infection, SIRS criteria, and organ dysfunction that is either a lactate greater than or equal to 4 or persistent hypotension evidenced by persistent hypotensive or new hypotension or new onset of 1 hypotension present within 1 hour after the targeted ordered volume of crystalloids fluid was completely infused. So that is based on the latest CMS guidelines. Now, initial resuscitation, I feel like it's important that we kind of review this as well. I'm going to go over 4 areas here to kind of give you a comparison so you get a understanding between the two, because it can be a little bit confusing at times. But initial resuscitation, they originally said 30 mil per kg in the first 3 hours. Now, the statement over on the 2021 side for patients with sepsis-induced hypoperfusion, we suggest that at least 30 mil per kg of IV crystalloid should be given within the first 3 hours of resuscitation. We suggest using balanced crystalloids instead of normal saline for resuscitation. They also had no change from over here where it mentions we need to be using dynamic resuscitation markers. You can do a passive leg raise, targeting that MAP of 65, reassessing hemodynamic status to guide resuscitation, and normalize lactate. They did add one statement about suggesting the use of cap refill to assess resuscitation. Now, let me just mention really quickly about dynamic assessments. So basically, you can do a dynamic assessment. You can place a patient on non-invasive hemodynamic monitoring, and you can look at the patient's stroke volume and see if they have an increase in stroke volume with fluid initiation. Now, that can be done 2 ways. We can do that with a passive leg raise, and we can do that with a small bolus. Now, the bolus would be 250 in less than 5 minutes, or 500 in less than 10 minutes. Okay, it's really important that we give a fast bolus to assess that heart to see if it can help forward flow fluid to help improve perfusion. If their stroke volume increases by 10% or greater, then that patient is considered fluid responsive, and hopefully fluid would benefit that patient. However, if they are not fluid responsive, that patient cannot accept that fluid and help to improve perfusion. The heart is not likely to necessarily do well with a bolus. So you can do this, like I mentioned, a passive leg raise, or you can do it with a quick fluid challenge. Now, we're going to go over how we can do that in just a moment. But really quickly, one of the other things I mentioned is that it states that we should consider the use of balanced solutions. So when we look at balanced solutions versus saline, so our balanced solutions here are lactated ringers and then this electrolyte solution. And then let's look at sodium chloride. Notice the pH of sodium chloride. Notice the high sodium content. And what we have found in quite a few studies is that sometimes these patients develop this hyperchloremic acidosis. And so there's enough evidence now to say in the septic population, the suggestion is to utilize balanced solutions. Now, it's not talking about traumatic brain injury. So TBI, I want to say that's a little different, and they recommend the use of sodium chloride for that patient population. But for the septic population overall, without excluding that area, they're suggesting balanced solutions. And notice you can see with lactated ringers that pH is much better. And with this electrolyte solution, it's even better. So you can go down here and see that. And I have found that people are surprised by that. They didn't realize how acidic sodium chloride was. And this study really kind of talks through this balanced crystalloid solution. And what I wanted to mention more than anything was that when we are looking at our plasma versus when we give lactated ringers versus when we give electrolyte solution, I really want to focus on when we use saline, what it can do potentially to the cardiovascular system and the renal system. And like I mentioned, that increase in metabolic acidosis, an increase in renal artery vasoconstriction, and it goes on, but you can read that article if you would like later. So now what does CMS say? Because I just talked to you about what the national guidelines say. Well, what does CMS say for fluid bolus? Well, let me just show you this. I'm in no way going to be reading all of this, but I just wanted you to see all of this data that these abstractors have to know about. And it's very specific, the timing and what solution they can have and how much they get, etc. Notice how much they have. I specifically wanted to just show you every single page that those abstractors. So props to all the abstractors who may be on the line. That's a big job. Now, one of the things I did want to mention, though, because I think it's really important, that CMS, since they update every 6 months, they have the ability to update a little quicker than the national guidelines. So they have said that if there is documentation that the patient has an implanted ventricular assist device prior to or at the end of time of identifying the need for crystalloid fluid, regardless of the volume and rate of crystalloid fluids ordered. Also, if the physician, advanced practice nurse, or PA or nursing document indicates patient or authorized patient advocated has refused IV fluid administration prior to or within 6 hours following presentation of shock. These 3 areas give the people or give the ability for the hospitals not to give fluid to these patients. Okay, this is what this is explaining. The last one is that the physician, APN, PA, or nursing documentation indicates no crystalloid fluids were ordered because the patient was not volume or fluid responsive. Documentation has to be indicated that invasive or non-invasive measures of cardiac output, cardiac index, stroke volume, or stroke volume index was used to determine the patient was not volume or fluid responsive. So you do have some opportunity to not give the fluid if you feel like your patient would not tolerate it, if they are not fluid responsive. Now, what does that look like? Well, I think we have to help our providers out. We have to help nurses out. This is just a sample progress note that I helped develop at the hospital where I'm affiliated with. And the part that I wanted to mention to you that I think is so important is really helping to spell out what has to be documented so you can get credit for what you do for these patients. So notice if your patient is getting fluid, if they're getting the 30 ml per kg, making sure that it's documented. If they are obese or their BMI is greater than 30, we can give weight-based fluid based on ideal body weight, but you have to document the ideal body weight. If your provider feels like we need to give less than 30 ml per kg of crystalloid, the specific amount still needs to be documented on what we're going to give and how much. But then you have to document the reason for not administering that 30 ml per kg. And you can, these are just some sample. And then patient not to receive fluid based on, as long as you have one of these documented, you should not get dinged for fluid. And I don't know about you, but that seems to be, fluid administration seems to be one that a lot of hospitals fall out on. And this is just the end of that progress note going into that 6-hour bundle as well. So let me just show you how this can work. I've kind of taken a case study and just did a few little samplings of how we can use non-invasive hemodynamic monitoring to help us get the right amount of fluid for our septic patient. So a patient is 60-year-old female, arrives to the emergency department with a persistent cough and fever. It's been over a week of symptoms. She thought she could fight the infection off by rest and Tylenol. She's hypoxic, started on BiPAP, but remained hypoxic, so had to be intubated. And she is started on the sepsis bundle in the emergency department. You can see she has a temperature, she has a low blood pressure, she has a high heart rate, high white blood cell count, lactate's high, BUN, and creatinine. You can see the creatinine has a bump and procalcitonin is elevated. Now, they did start the patient on the bundle. She got a liter of fluid and then was connected to the non-invasive hemodynamic monitor in the emergency room to give fluids based on patient fluid responsiveness. So let's all answer this question, and you can just type your answer in the chat. What type of solution would be best for resuscitation since this patient is septic and not a TBI patient? So is it saline? Is it lactated ringers? Is it that electrolyte solution? Or is it B and C? Take a second and type in the chat. And the answer is B or C. That is those balanced solutions. That are the balanced solutions that we talked about. Now, what criteria does this patient meet based off of CMS definitions? Do they meet A, sepsis, B, severe sepsis, or C, septic shock? I'm going to have you go ahead and type that in the chat as well. A, sepsis, B, severe sepsis, or C, septic shock. And hopefully you said septic shock because the patient had a known or suspected infection, had surge criteria, had organ dysfunction with a high lactic acid, and also was hypotensive. Okay, so our question always should be asked, is this patient hypotensive or hypoperfused? Yes, this patient is. Patient has a low stroke volume and low TPR, so they're a little bit dilated. So we are going to do a passive leg raise or a small fluid bolus, and this patient only is 4.4% responsive. Now, what should we consider next based on the fact that the patient's only 4.4% responsive? Well, we're not going to consider C, right? We're not going to give balanced solutions because the patient is not fluid responsive. Are we going to consider giving a vasodilator? No, the patient's already dilated, right? So are we going to give vasopressors or an inotrope? Feel free to put that in the chat. And the answer is we are going to start with the vasopressor. This patient has a low stroke volume and is also kind of dilated out, so we need to tighten them up. So we started a vasopressor, we increased that over the next hour, and we noticed this patient is still only has a 60 mean arterial pressure. So we go ahead and do another passive leg raise, and we find that the patient is still not fluid responsive. So we consider adding another pressor. And I'm going relatively quick because I want to get to all the good stuff today. And hopefully feel free to reach out. We can give you a copy of this information so you can review it at a little slower pace if you need to. 3 hours later, the stroke volume dropped again, and followed by a blood pressure drop. The patient's on 2 different vasopressors. And so, yes, the patient's hypotensive. We do a passive leg raise. And lo and behold, the patient is fluid responsive. So we are going to give some balanced solutions. All right, so that's how that works. I'm going to skip through these next few slides because I want to get on to the rest of the information and then also give you some time for some question and answers. But that's how that dynamic resuscitation can work to allow you to get precise fluid management, right? And CMS is allowing for that now. So I think that is a good thing. Now, vasopressors. Vasopressors, mind you, were back on the national guidelines. There were no change from 2016 and the 2021 guidelines, except they suggest starting vasopressors peripherally to restore MAP rather than delaying initiation until central venous access is secured. So norepinephrine is the vasopressor of choice. And I do want to mention this, though. We do need to develop a policy for safe peripheral administration of vasopressors, right? If we are going to give them peripherally, we want to make sure that's done safely. There is plenty of evidence now. Trust me, I was a big one saying they needed to have a central line before they came to ICU. And now I've changed my stance on that based on the evidence. We can safely give peripheral vasopressors, but we want to make sure it's done correctly. Now, CMS, I'm not going to read this again, but as you can see, they've got a whole list of what you have to do in order to get credit for the appropriate vasopressor, as well as the timing of vasopressor administration. Next is antibiotics. So these are the national guidelines. And one of the things they mentioned for 2021 that's a little different than what they had in the past is they had a moment of pause. Now, for adults who with possible septic shock or high likelihood of sepsis, they recommend administering those antimicrobials immediately, ideally within 1 hour of recognition. And for those with possible sepsis, they suggested a time-limiting course of rapid investigation. And then if concern for infection persisted, providing those antimicrobials within that 3-hour time period. And then they recommended not giving empiric MRSA coverage for patients who are not at high risk. Now, CMS also has quite a lengthy list of all the requirements for antibiotic administration. I'm not going to read every single one of those, but it is pretty daunting if you are a abstractor, but you can do it. And there are abstractors out there who are amazing and have really learned the importance of really looking all the nooks and crannies of our documentation to find the right answers. All right, next for best practices for sepsis teams, I'm going to move away now from the guidelines. I just kind of focused on 4 areas. We didn't have enough time to go through every single area, but I want us to move on to some other best practices as well. Secondly would be screening for sepsis detection. I'm a firm believer you should screen at least every shift, PRN when patient has changes. You can utilize automated tools to help detect changes, but there also needs to be some ground rules with that. Now, when you think about early screening, that means is early detection, right? Manual screening based on the patient's presentation. This can be added to the EMR, electronic medical record. But basically, you want to know, does the patient have a known or suspected infection? Do they have SIRS criteria? And do they have organ dysfunction? And if they have that, then what are the next steps? Like you can see here, I've spelled out lactic acid stat. If question 1 is yes, they have a known or suspected infection, and question 2 has 2 or more SIRS. Anyway, it spells out really what to do with next steps. And I think that's super important. Next is thinking about utilizing some of those tools I mentioned, the modified early warning scores, MEWS and PEWS, which is pediatric early warning scores, automated alert systems. There is nothing wrong with using an automated alert system. In fact, I would recommend it. However, I think it's important that if we are utilizing that, we need to know what's happening with those best practice alerts that is being sent out to the nurse or to whoever is in the electronic medical record to follow through with the protocols. What happens when that alert is paused or told to be silenced? Is there accountability? Is there anyone who's monitoring those automated alerts? I know we can get overwhelmed with all these alerts popping in our face, but we have to do the right thing. And how do we know if those are being done correctly? So another opportunity is there are now in place, there are bed features that will also help you. Some beds now offer continuous monitoring of heart rate and respiratory rate, which are 2 leading indicators of deterioration. And what can happen is that heart rate and respiratory rate will elevate. So the alert then would be sent to the nurse's station or to the nurse via their communication device to say, hey, Ding, 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 this patient is showing signs of deterioration. So that's another opportunity for us as well. This is just a sample of the severe sepsis screening tool audit that we put in place that I developed for my hospital, where we literally looked at, I would recommend to the directors, 10 patients or so a month, to where we just randomly select 10 patients and see, are patients being screened appropriately? Are we doing what our protocol says to do? Because we have a nurse-driven protocol where we can start the blood cultures and the lactic acid. Are we doing what we're supposed to be doing? And really looking at that. So I think if there was one thing I would really encourage you guys to do, if you don't have an accountability for your screening, accountability for those automated alerts, there really needs to be some kind of a tool to determine if that's being done appropriately. The next thing I want to mention is evaluating your program. How can you evaluate your program? Well, there happens to be an amazing source that just came out in August of last year by the CDC. And this is the Hospital Sepsis Program Core Elements for 2023. And they focus on 7 areas. And I just want to mention what those 7 areas are with just a one-line statement of what that means. And let me tell you, if you would like me to send this to you, I can, or you can. It's out there. It's for everyone. There's no cost for it. And it's a beautiful document that really helps you assess how well your program's doing. But the number one is hospital leadership commitment. Do you detect the necessary human, financial, information, technology resources? Do you dedicate that amount of time for all those necessary needs? Accountability. Have you appointed a leader or co-leaders responsible for program goals and outcomes? The next is multi-professional expertise. Are we engaging key partners throughout the hospital and the healthcare system? Are we taking actions, implementing structures and processes to improve the identification of, management of, and recovery from sepsis? As far as tracking, are we measuring sepsis epidemiology, management, and outcomes to assess those impact of sepsis initiative and progress toward program goals? Are we reporting? Do we provide information on sepsis management and outcomes to relevant partners? And are we educating? Are we providing sepsis education to healthcare professionals, patients, and families, as well as caregivers? So there is a lot there. And what this tool does is it gives you documentation on each part. I just gave you a one sentence on every topic, but it gives you a very clear and robust information about each section. And then for each section, it gives you questions to ask at your facility. Are we doing this? Is this established? What can we do to make that better? Now, based on that, they also did a 2023 NHSN annual survey. And maybe some of you were part of that survey and you sent your information in. So the question they asked, and this was a very recent publication, it just came out in 2024, and there were over 5,000 responding hospitals. 78% reported having sepsis committees. 59 had sufficient dedicated time for sepsis leadership. 67% reported sufficient data analytics and resources. Usability or acceptability of sepsis tools was tracked by 45% of hospitals. 64% used antimicrobial orders that defaulted to immediate administration in cases of suspected sepsis. Now, here's where it gets a little less, and these are more of our higher opportunities. 32% reported standard processes for verbal handoff. I think that could be a very important thing for us to do. 32% reported standardized screening for new functional or cognitive impairment. We're going to talk about that in just a moment. 38% provided patients with contact information for clinical staff at discharge, and 22 to 23% reported sepsis education during onboarding and annual sepsis education for CNAs and patient care techs. So, conclusions to that publication that just came out was that there was modest initial progress in resourcing hospital sepsis programs, but there were still many opportunities, as I mentioned some of those there, to optimize that patient care. We know it is so important to have executive sponsorship, to evaluate the usability of local sepsis tools, like I mentioned, implementing processes to support that sepsis recovery, continually educating even the CNAs and patient care technicians, because many times they're the ones doing the vital signs, and implementing processes to support prompt antimicrobial administration, as well as improving access to key sepsis data. The fourth best practice for sepsis teams is just to continually try to better your program. You can try to do that with certification. I know that's one thing that they mentioned in my bio. That is one thing we did, and I'll explain a little bit why we did that. But also working with EMS, so our emergency medical systems, home health care, providers, offices, et cetera, to increase awareness and identification. Now, why might I have suggested certification for a hospital? Well, I feel like it demonstrates a commitment to a higher standard of service. Also, it provides a framework to improve patient outcomes. It also keeps us very focused. When you know you're going to have a reviewer come in and look at your processes, you are looking at it very closely. It also helps to organize teams across the continuum of care. I know it did for us. And then it gave our sepsis team validation. It showed our patients that we were committed to providing consistent clinical quality. Now, working with EMS, this is just one sample, but this is the group I worked with EMS to care for these patients. Now, I live in a more rural area, hence why I have so many animals, right? I'm much more rural. We don't have a hospital on every corner of our streets. And so our patients could be in the rig of an ambulance for 45 minutes to an hour. So we knew that it was very important that they would start getting that treatment and care. So they have the ability to declare code sepsis in the ambulance. They can do blood cultures in the ambulance. Yes, we do track their percentage of contamination. And let me tell you, it's typically better than the hospitals. It's hard to believe because they're in the field, right? They also moved from dopamine to norepinephrine in their rig, and they also started carrying antibiotics in their rig. So it can be done. And especially if you're one of those more rural hospitals, I do encourage you to really work with your emergency medicine system. Now, what is brand new? And this was new for me. I learned this in preparing for this presentation. There is a new encounter for sepsis aftercare. It's called code Z51.A. Now, I want to, before I go into a lot of detail about that, why might we need an aftercare code? Well, there is this thing called post-sepsis syndrome that is very real. It affects up to half of all sepsis survivors. The term is used to describe the group of long-term physical, cognitive, and psychological effects after surviving sepsis. Some of the long-term consequences may be insomnia, difficulty getting or staying asleep, nightmares, having panic attacks, hallucinations, disabling muscle and joint pains, decreased mental functioning like fog, loss of self-esteem and self-belief, organ dysfunction, things like kidney failure, respiratory problems, and some have even lost limbs. And action items from the CDC Core Hospital Elements Program under action improve the recovery of sepsis. Now, in those action items, they talk about this. So I'm really happy to say I'm excited about this. Now, this is brand new. It's not even live yet. But currently, there's no way to code post-sepsis syndrome in an ICD-10 CM at the present time. Okay, so as of October 1st, 2024, based on the references I had, this code should be available for use. Now, how we can utilize it would be to follow up after hospitalization for sepsis, home health continuing care, physical or occupational therapy. Also, in some of our post-acute facilities that need to explain why they are treating ongoing sequela. So our patients need this and deserve this. There is a lot of follow-up that needs to be done for this sepsis aftercare based on post-sepsis syndrome. We could do a whole hour on post-sepsis syndrome. I did want to mention that we have medical education websites where you can get information about sepsis and fluid management, and there's a QR code there.